Hello, my name is Dr. Matthew Bramlett. This is me over here. And in this lesson, what we're going to discuss is oxygen in the blood. And we're going to start by going through the arterial oxygen content of blood. We're going to also understand oxygen, that differentiate between that which is dissolved in the blood versus that which is bound to hemoglobin. And we'll move into the O2 dissociation curve. From there, we'll discuss delivery of oxygen to the tissues and oxygen consumption and understanding its relationship, the delivery of oxygen's relationship to cardiac output. From there, finally, we'll get to the point of understanding the Fick equation, which is understanding flow, and run through all of that. And the primary purpose of this lecture is in order to get to the point where we can calculate flow going to the lungs, the pulmonary circulation, as well as the systemic circulation, requires an understanding of how we can calculate that in its entirety. And this is a good foundation for allowing us to then move eventually into shunting lesions through some of the following lectures. Thank you. So the first thing we're going to discuss is the arterial oxygen content in blood. And so in dry air, you have 760 millimeters mercury is the equals 1 atmosphere, also equals 760 torr. Of that, there's 160 millimeters of mercury, which is 21% of the 760 that constitutes dry air, whereas PCO2 is 0.25 millimeters of mercury. You breathe it in, it combines with water, which decreases the content, but the primary factor, which drops 160 to 100 in the alveoli, so PO2 in the alveoli is about 100, is the fact that you've got so much carbon dioxide in here pushing it around. So oxygen is in the alveoli, the capillary bed. You have blood coming through, which is the plasma as well as the red blood cells. And due to a very efficient system, we can maintain a PO2 of about 100 in arterial blood. And so from here, oxygen moves around to the body. It's extracted by the tissues, where you can follow the PO2 here in venous blood, and returns where it's once again taken out of, CO2 is taken out and the O2 is refreshed. So there are two components when we discuss the arterial oxygen content of blood. First, you have, let's start down here, sorry. The arterial oxygen content of blood is the milliliters of oxygen per liter of blood. In pediatric cardiology, we use liters per blood, liters of blood because of a lot of the calculations related to flow. You'll find a lot of deciliters. In order to understand how that all relates, I'm going to describe this once, and if you ever get confused, we'll just come back to here. Essentially, in the equation, we have this 10 factor here to convert from deciliters to liters. And you'll also know when I'm talking about the dissolved content, I'm using 0.03 per liter instead of 0.003 per deciliter. Those are a couple things. You really don't need to know the dissolved versus bound. But let's talk about this equation here, which is arterial oxygen content. You have hemoglobin in grams per deciliter in the blood. You times it by 1.36, which is the constant, which is at 1 atm, you have 1.36 milliliters of oxygen in a fully saturated hemoglobin per 1 gram of hemoglobin per grams per deciliter. So this is the sort of the constant which is applied to convert how much oxygen is on a hemoglobin. You're going to multiply that by the saturation. So if it's only 60% saturated, you're obviously not going to have this whole thing. Plus the amount of dissolved oxygen. The dissolved oxygen is actually pretty low, and Henry's law here determined that this is the sort of solubility constant of oxygen in blood here, which is for every liter of blood, 0.031 mils per millimeter mercury. So it's a couple things to know. Normal is 18 to 20 deciliters, or if you're talking deciliters, but it's 180 to 200 oxyhemoglobin plus the dissolved O2 in a liter of blood. Of that, about 197 is oxyhemoglobin, and only 3, so less than 2% is dissolved. And a lot of times this drops off. So normal's around 200. So really the main thing to account for here are the different components, the understanding the constants. If I work through one equation where we have hemoglobin times 1.36 times 10 times saturation of this, what we get is 205. So my hemoglobin's a little high here for rounding purposes. 100 is PaO2. Again, in a normal instance, 1.5% accounts for how much is dissolved. But so the predominant factors are what is your hemoglobin and what is your oxygen saturation to really get to understanding what is the true definition of arterial oxygen content in blood. So last lesson or learning objective focused on dissolved O2 in the blood. This is going to be more along the lines of bound oxygen in the blood, and it's bound to hemoglobin. Hemoglobin is a molecule that allows oxygen to bind to it, and a conformational change occurs on the hemoglobin molecule. And its resting state, it's very tense. And while it's tense, that means it's not readily accepting of hemoglobin. And when it's destabilized and the conformational change occurs, it can attract more oxygen onto it. So you can imagine anything that increases the acidosis, or a situation where there's increased acidosis, high temperature, or high CO2 level, will sort of make it more tense, bring it closer to that sort of normal state, which means as it becomes tense, it loses its affinity for oxygen and releases it. So if you think about the O2 dissociation curve, which we have here, let's orient you to the graph. So this is the percent hemoglobin, percent oxygen of hemoglobin. So it 10%, 30, 50, 70, 90, 100% SaO2, right? This is the millimeters of mercury of oxygen in the blood. So down here at 40, this is a resting cell. So This is where this number comes from. And at the alveoli where we have our 100 millimeter mercury. And so what you can see is the purple line here in the middle represents sort of the normal. And things that shift the curve to the left include alkalosis, hypothermia, hypocarbia, fetal hemoglobin. Things that shift it to the right include acidosis, hyperthermia, the opposite elements. And when you consider what's happening, so we've got an oxygenated hemoglobin, fully saturated here. And as it gets close to the tissues, what are we seeing? We're seeing, if you think about it, a patient in exercise, they may be releasing some lactic acid, their increased temperature because of the exercise, increased CO2 production. And so it's going to, when it gets down close to the tissues, become more tense and releasing a lot of that oxygen, which will quickly equilibrate across the membranes into the cells. And that's how oxygen is delivered. When we get back up here, and now there's an abundance because the oxygen in the venous blood is 40 millimeter mercury, it starts to attract a few oxygen molecules, which works towards that destabilization of the molecule and binds to it here. And so when you're considering the O2 curve, it is a dynamic process where the state of the surrounding environment in the tissue changes as you go around from the lungs to the tissue. And you'll also notice that if you consider a fetal circulation where the umbilical vein is returning back with the highest amount of oxygenated blood, it's coming back with 69, 70% saturation. And in order to allow more blood or more hemoglobin to really get to the tissues, or for the hemoglobin to really be more optimized for that lower saturated state, we have fetal hemoglobin that helps to account for that. And finally, what we're talking about in this instance here is this part of the equation, which is hemoglobin times 1.36, conversion factor of 10, times oxygen saturation, which is 1/2 of the arterial content of blood, which accounts for 97, 98% of oxygen in the blood. In this learning objective, what we're going to cover is the delivery of oxygen to tissues, including cardiac output and its relationship with preload, afterload contractility, and then go through some examples like what occurs in anemia, as well as review briefly VO2 consumption, or I'm sorry, oxygen consumption, which is VO2. So when you're discussing any sort of a patient in shock or any sort of a state, the delivery of oxygen to the tissues is critical. It's not just what is the content, but it is how this the cardiac output combines to deliver the arterial oxygen content. So delivery of oxygen to tissues is flow, which is Q here, times the content of oxygen in the tissues. And so, as stated before, cardiac output is a relationship between stroke volume and heart rate. And stroke volume is impacted by preload, afterload contractility, where preload is how well does the heart get into a state to maximally be effective. Afterload is what pressure against is the heart pumping, and contractility is how good is all that calcium binding and moving the tissue. So the other thing to consider here is going to be what is normal oxygen consumption. Now, you're going to find this is a hard number to find. It's measured by putting somebody in a hood and measuring the amount of oxygen coming in versus that which is coming out of this big hood, and can be directly measured for accurate values. But for all intents and purposes, 250 milliliters per minute is oxygen consumption in an adult. In pediatrics, sometimes we'll use 150. There are different nomograms. This is 3.5 to 4 milliliters per kilo per minute is one way to calculate that, but it's still, there's so many things that impact it. It's hard really to come up with a precise number. If you think about it from an adult standpoint, in a normal resting state, if you're consuming 250 milliliters per minute, and what we're delivering is let's say normal content's 200 milliliters, and we're delivering 5 liters per minute, we are more than enough delivering, that's 1,000 milliliters per liter that we're delivering to the tissues. And so there's a lot of redundancy built in a resting state, which is how we can rest. So another critical component here is to understand, we're going to run through an example. So if you recall in our first or the last lecture, we described how arterial oxygen content, you've got 15 hemoglobin and essentially 100% saturation on room air, which is indicated by the 100 here, gives us about 205 milliliters oxygen per liter, and the dissolved content is less than 2%. One of the things that I found interesting when I was studying this through PALS was if you have a patient who comes in an anemic state, what is it that you can do that can actually have some degree of an impact on the delivery of oxygen to tissues? Well, the simplest thing you can do is to get their PO2 up. So non-rebreather mask 100% oxygen can actually increase from 68 at a baseline here, you can see that, to 83 here. That's a 18% increase in oxygen to the tissues, which in a stressful state can actually be pretty impactful. And so most of the time, we're going to drop this off the equation, but it's only whenever you get up to very high PO2s that it can begin to impact the equation, and most especially when you have an anemic state present. So in mixing congenital heart lesions, it's rare to be able to even hit that 500 number, which is why a lot of times we just drop it off. So for our final learning objective here, we're going to be discussing the Fick equation as it relates as a measure to measure cardiac output. So Fick equation says that the oxygen consumption divided by the arterial or blood content difference gives us flow. For example, we have QP and QS. QP is what is the pulmonary circulation, the flow through this circuit. The systemic circulation is here. So let's walk through, for example, QP and QS. QP, I have oxygen consumption divided by the veno-arterial content difference. And so pulmonary venous is obtaining a saturation from the left atrium or the pulmonary veins, and the pulmonary artery is obtaining it from the PA here. So in this situation, it's 95 and 75. And if you look down here in our QP full equation, you'll see I have 0.95 listed here and 0.75 listed here. For the systemic circulation, I have the systemic arterial oxygen content minus the mixed venous. And that would be the systemic artery coming from the aorta, mixed venous. You can better appreciate this here. I have the aorta and mixed venous. Typically, you've got a lot of stuff going on in the right atrium here. The head sats are lower because your brain's pulling out extra oxygen, and you hope it is. Here's the IVC with slightly different coronary sinus comes in back here with a lower sat. So typically mixed venous, we get proximal SVC. So if we take these elements, in the absence of a shunt, we're going to, whichever circulation, we should get the same values out of each circulation. In pediatric cardiology, we're very concerned about the differences due to shunts, whether they be at the atrial, ventricular, or extracardiac structure level. So if we walk this equation out, we have QP listed here over QS. So if we take QS and invert it, so we now have VO2 over pulmonary vein minus pulmonary artery times the inverse, right? So we're just converting this to here. You can see how we can eliminate VO2 to get us to the ratio equation, which allows us to obtain saturations in the aorta minus mixed venous sats over pulmonary venous minus pulmonary artery sats. And that's how we can get to the ratio. What I want to do real quick here is show you how we actually get to this equation to sort of run through everything. So this is sort of the longhand division version of determining pulmonary blood flow. Assuming these parameters here, we have 150 VO2 divided by the pulmonary venous oxygen content, and you can see the two components of the equation, minus the pulmonary artery oxygen content, and you can see those two components here. Of note, the 0.95 is from this location, the 0.75 is from the pulmonary artery here. So whenever we calculate all the math out, we get the QP of 4.05 liters per minute. In the absence of a shunt, which this diagram here is in the absence of a shunt, you can see that the aorta minus mixed venous is also 0.95 and 0.75. And so you can imagine how you can take the simple sort of QP-QS relationship here and get a 1-to-1. Of note, here is sort of a quick rundown of the different elements. QEP is effective pulmonary blood flow, and you're going to get lost if you kind of dive into that. But for the time being, the main thing to be aware of in this instance is a left to right shunt indicates that you've got more blood going through the pulmonary circulation. So this would, for example, be 2-to-1. A right to left shunt would, example, be 0.85-to-1. You're going to be cyanotic in right to left shunt. Right to left shunt would be a VSD, where you have blood coming to the from the right ventricle to the left ventricle, for example, due to a restrictive pulmonary valve in a tetralogy of Fallot. A left to right shunt would be, in the absence of obstruction, the flow returning to the left side. Same thing can be said for the atria.